We're going to talk about new meds that are coming up, new problems, or at least problems that are newer since we began treating more effectively. Looking at old problems and maybe some new treatments for them, new news about old meds, a little bit of a view about the virus, some new information perhaps, and also about your immune system, or maybe the link between the two, new ways of looking at that. And then I thought I'd touch on vaccine information as well, since every now and again that comes up, although I can tell you right now we don't have any brilliant answers there. When I talk about meds, I just want people to understand the process in this country about how meds actually get into your hands and the way we can prescribe them. There's a process that the Federal Drug Administration uses to investigate the effectiveness and safety of medications before they actually can be released to the market. So there's this very formal process with different phases, 1 through 4, and without going into great detail, it's essentially looking to see, does this thing look like it's going to be effective at all? Then a question about, is it safe, and how effective it is, and then each stage along the way, as more of that information is gained, they're expanding the use of the drug in studies so that more and more people are involved in the studies. And initially it might be as simple as animal studies and laboratory studies in terms of test tube stuff, and then it moves into human beings and looking to see how does the drug metabolize, how long does it last in the system, after having already looked to see what does it do to the virus, and then how safe does it look in people, how effective is it in a clinical manner in terms of how somebody's health is when it comes to the virus, and then finally going into longer term studies that actually look to see, okay, how does it compare to stuff that we already have, so that we would have an idea about, is it better or is it at least as good as what we're already doing. And then finally it gets approved, and there are still what are called what do they call them? Post-marketing studies. So essentially drugs that are approved, when they're new, there's not as much information as perhaps a drug that's been out there a long time, and so they actually still continue to monitor how people do, particularly for side effects or complications, because sometimes the studies have only involved a certain number of people, and some of the complications may not be as evident in those initial studies as they are after it's been released. So occasionally you'll find out that drugs have different or more complicated side effects than perhaps had initially been appreciated. And then finally there's a subsection of this which is called expanded access. Is anybody here aware of that or on a drug through expanded access? I see one hand. So expanded access is a process by which the FDA allows drugs to be prescribed in a formal study for people who need the drug, and there has to be a demonstrated need in the sense that that drug is going through the process of approval. It is not yet approved, but it's understood and has been evaluated enough by the FDA to say, hey, this looks really good, we think this is going to go, but we're not there yet. However, there are some people who might need this sooner than we can go through our formal approval process. So we're going to allow them to have it through this process called expanded access. And those folks, even though it's in a study, they all get the drug, but they're very closely monitored. And you can only get it through usually an organization or a physician's office that is willing to go through all the paperwork and whatnot. So depending on where you go, you may or may not have access to expanded access because of the fact that it has to be so formalized. You've seen this. I know you have a handout with something similar. I'm just putting it up there to remind us of what we're talking about and where things work. And I know this has been beaten into your heads in the past as well as here today, but it is relevant when we talk about individual drug classes. So you can see what I'm going to talk about first has to do with the drugs that are currently, the classes of drugs that we routinely use and can prescribe now. Here's the virus coming in, there's the new ones going out. We're looking at drugs that are currently available. We have some T20, which is blocking things at the entry into the cell. Then we have our reverse transcriptase, and we have two classes of drugs in that, and I know you heard some of this before, the so-called nukes and non-nukes. And then finally we have this protease activity over here, and that's where protease inhibitors work. So those are the first groups that we'll talk a bit about, since we already know something about them. So new meds in these groups. So PIs, that's protease inhibitors. There's a couple that are actually now prescribable that are new, and I know that Jim went over this briefly. One is darunavir, which has its old name of TMC 114. I really cannot do anything but say that there are multiple names for each drug, and probably the best thing is to ultimately learn what's on your bottle, because that's what most people are going to see all the time. But just realize that people will throw terms around because they'll use the original name when it was in studies. It becomes familiar to people, particularly if it's in expanded access, because that's the only name there is. And then later it gets its other names. So they accumulate names the way the virus accumulates mutations. I mean, there's a bit much in the naming. So darunavir is one of the new protease inhibitors, and topranavir. Both of those are prescribable at this point. I think the key with this is that they both have properties that show response in people who have experience and mutations against other protease inhibitors. So there's a good chance, not a guarantee, but there's a good chance that someone who's got problems with mutations and resistance to protease inhibitors may respond to one of these drugs. There's a little bit of some specifics around when that would or would not be likely to happen, and that's what would have to be sort of dealt with by any provider talking to their patient. But that's one of the possibilities, either one of those. The darunavir probably looks a little better from a couple of perspectives, including drug interactions, less in the way of drug interactions, which makes it always simpler when it comes to a prescribing perspective. There's another drug that's still in studies called, I don't even know if that's the way to pronounce it, brincanavir, whatever. And those look good in terms of the studies, but it's still in one of those earlier phases, so not an expanded access, not prescribable at this point. When you get down into this group, this is the so-called NUCs class, so the nucleoside reverse transcriptase inhibitors. We just call them NUCs. This is the class of drug with AZT and 3TC and that group of meds. There's not a whole lot in the near future with those. There are a couple that have been in studies that look pretty good, particularly around the issue of resistance. This is the name of the game when it comes to new drugs. You either have to have something that works in a completely different new way to expect that previously resistant virus will respond, or if you've got a drug that works in a similar way to drugs we currently have, there's got to be something different about it for you to think that it's going to actually work well in somebody who's already drug experienced. And so these two drugs look like they have some activity with resistant strains of HIV. So that's why they're moving ahead, and those are possibly in the future. Those are a little further behind, at least to my knowledge. And then we have the non-nuke class, which is the group that has Sestiva in it and Viramune. Those are the two that are most commonly used now. This drug, TMC 125, also known as etravirine or etravirine, I'm not sure which, is actually in expanded access now. And again, the reason for that is because it shows promise in folks who have some resistance to that group that currently exists, which is a big issue in that particular drug group, because single mutation, one change in the virus in somebody who's taking one of the current ones like Sestiva or Viramune can lead to resistance, very high level resistance, which means that drug won't work, and the drugs currently in that group will also not work. And this drug appears to offer some hope that actually you're going to have a response even if you've got that mutation. So that's why there's some excitement around that. So back to our life cycle again. Now we're going to talk a little bit about some other steps. We didn't talk about this area even though there's one drug in it, and that's so-called T20 or Fusion. This is the entry inhibitors. We'll go a little bit more into how things work there just briefly so you understand that they are not all working the same way, even though they're blocking the same step. So that's an important thing to realize, that this group that are going to block the virus getting in don't all work the same way. Then we have integrase inhibitors. So this is something new. We haven't talked about this before. Maybe you've been hearing it here, or maybe you've been reading on your own. But the life cycle of the virus, there's one funky thing that people sometimes forget, and that is once that virus has made DNA, once it's gone from its viral form of genetic information into the human form of genetic information, it actually becomes part of your cell, part of your chromosome, part of your genetic information in that cell. And the way that it does that is, once that DNA is formed, it brought along this thing called integrase, and it integrates it into the chromosomes in the nucleus of your CD4 cells if you are infected. That means that until that cell dies, it has that information, okay? So as bad as that sounds, the good news is it's another place that we can try to stop the life cycle, that we can try to slow things down. There's a question over here.
Is there a time frame in between the time that enters that cell and becomes part of the DNA in each person?
So the question is there a time frame between when the cell becomes infected and when it integrates? And the answer is yes, and the second part of the answer is I don't know the time frame. The life cycle of virus is quite rapid, so we're probably talking relatively short amount of time. I'm not sure exactly, but for example, when someone becomes infected, we know that the virus is able to reproduce from the time that, at least in monkey studies, that they get infected. I mean, within 24 to 48 hours, you're seeing new virus. So certainly shorter than that, and probably substantially shorter from the time a cell actually gets infected, because it has to go through the rest of the life cycle in order to produce new virus. So I think that the thought, and I'm not sure if this is a thought in your mind, but the idea that, oh, I can take this medicine and then I won't have this problem in the genetic code of my body, it's past that point if you're already infected. And the reason is all those other cells that are already infected already have it in their DNA. And this is the problem with actually the concept and the idea and the hope of a cure, is that you got to get it out. And how do you do that? And nobody knows. So that's why this whole talk about a cure is somewhat fraught with the idea that somehow you're going to get rid of every single infected cell. That's really complicated to think about. How do you do that safely to somebody? That's why we don't really talk about it a lot anymore. I don't know if that makes sense to folks. We'll come back to it if you have any questions. But so the time frame, I don't know the time frame, but it's short, okay? So that's a spot where we can slow it down though, all right? And then the other place is this area here, which is called maturation inhibitors. So maturation is not a fabulous new enzyme that's brought along with the virus. It's just that as the virus proceeds through the release from the cell, it actually has to, quote, mature. There are things that go on that continue to process how that viral particle is assembled and makes it functional. And if that maturation process, as we want to call it, is inhibited, then that virus is not able to go on and infect another cell. So it's another place that we can slow the virus down. This is a little bit more about the entry inhibitors, because I'm going to talk a bit about them now. And you don't need to remember all this, but the point is simply that if you look at what's happening in molecular detail when the virus binds to the cell surface, because it has to bind to the cell surface before it can fuse and get in, there are different parts of that process and different structures involved. And the medicines that are so-called fusion inhibitors work at different places, and therefore they can be quite different. So, for example, T20 works in this area right here, which is this part of the structure of the virus that has to go through this, what's called a conformational change. It has to go through this structural change in order to get that virus at the last bit of it right on into the cell. So T20, fusion, that's what it's stopping. The other areas are things like so-called CCR5 or CXCR4 inhibitors. And that has to do with other parts of the cell. You can see here that this is the CD4 molecule, which is what HIV binds to, but it binds finally and more effectively by also binding to what is called a coreceptor. And that's what this CCR5 and also the CXCR4 are, different types of coreceptors. And that makes it more likely that the virus gets in. So if you can block the binding there, that's another place to block things. And then finally, if you can block the binding to CD4, you might be able to block things. So there's different parts of that process that would mean completely different types of medicines that would do that, because they're very different actual structures. And we're really down to the issue of biology and biochemistry and what things will do what. And you can see, or you could imagine, that if something is structurally very different, then the medicine that's going to work to block that is going to be a very different medicine. Okay? So, entry inhibitors. There's actually, we're sort of going back to the future, or whatever we want to call it, back to the back. There's interest again in blocking CD4 entry. This was something that was long ago was actually done at the very beginning of the epidemic and was not shown to be very successful, but it was in a less refined way. So this is beginning to show some benefit, but again, early in studies. It's an IV, it's an infusion of so-called monoclonal antibodies, antibodies that would block the CD4, and therefore the virus couldn't bind to it, or they would bind to the virus. Fusion inhibitors, we talked about the current ones being T20. There's a so-called next generation, you know, we love abbreviations. This is a new one to me. I just found this abbreviation, the NGFI. So that's your next generation fusion inhibitor. So there's a couple of them. They still have their chemical study names, as you can see, TRI-999, TRI-1144. And the thing that's interesting about them is twofold. One is that they last a long time in the system. So for those of you who are on T20 or have read about it, it's an injection and it's twice a day. And this would be potentially a weekly thing. The other thing is that these drugs in initial studies have shown that they actually work even in strains of virus that have become resistant to T20. Okay? So that sounds promising, that sounds interesting, but more to come. Every time there's information about new drugs and you read about it in the paper, you see it on the internet, and there's some little study that showed that, you know, X% of people, this will work with them. If it's really early phase, you have no idea whether that's going to come to fruition. I mean, that is early on, and we've had a lot of drugs that looked great, looked wonderful, but it turns out they were super toxic, or they weren't as effective as the first study looked like. So a lot of this information, I'm trying to focus on things that are actually far enough along that they look like they might come, but there's no guarantees, okay? And then we talk about these inhibitors. Remember I talked about the coreceptors and how you could block that. The group that looks most promising is the so-called CCR5 inhibitors. So these are things that block the binding to the coreceptor. And the two drugs that look most interesting are Maraviroc, and I don't know whether this is Vicraviroc or Vicraviroc. She's going to tell me the right answer. She thinks it's Vicraviroc. How many for Vicraviroc? I think it sounds better. How many for Vicraviroc? Loser. Okay. So they both actually look pretty good in terms of being safe and in terms of being effective and in terms of working in folks who've had other drug experience, which isn't really a surprise because they haven't had this kind of drug experience. The issue is going to be, are they safe? Again, any new class, you don't know about long-term toxicity. There's some issue about there was a slight increase in malignancy in this study with Vicraviroc. However, there was in both arms of the study a little bit more in the group that got the medicine. Very advanced patients anyway, some of them who had previously had a malignancy. So it gets a little bit unclear, and this is early on. So, however, there's certainly something to keep your eye on because it's a new class, and that's always a good thing because it means there won't be resistance up front. Yes, the question.
What is the concern of risk of R5, that X4 transition? Is that a receptor?
Yeah, that's a good question. Okay, so what we haven't talked about is this. HIV, the business of the R5 and the X4, first of all, those are abbreviations for the CCR5 and the CXCR4. So most patients, if you look at what their virus uses to get into the cell, which coreceptor it uses, it's R5. Some patients, it uses X4. It turns out that patients whose virus uses X4, it's usually a more advanced stage of the illness when that's happening. So there's some question about if you force the virus into using X4? In other words, you block R5, does that push things towards X4, and will that therefore bring about a more aggressive virus? The odd thing about it is everybody has the capability to be or rather R5 or X4. It has to do with statistical correlates. It's not that we understand the process well enough to know. When they've looked at folks who've been on these meds and looked to see what happens, even those who had mixed populations, in other words, the virus, some of them use the R5 and some of them use the X4 to get in. There are patients who you can find who have some of each. When they're given the R5 blocker, they did not get progression any more differently than folks who didn't. In other words, it didn't appear to push them into a more advanced, more active, more problematic virus. But it is definitely a concern, and actually most of the studies of these require, from a safety perspective, that people start off with only R5 because you don't want to know that there's X4 already. But it's a really important point. Does that, it's a little bit perhaps complicated.
Well, at least there was no change within the timeline of the study.
Right, and to be honest, I don't remember the length of the study. It might have been 24 weeks, or I'm not sure. So the other classes we were talking about were the integrase inhibitors. This is the part where it's blocking it from actually integrating into your chromosomal DNA. And there's a couple of them that look very promising. So one is this MK0528, and the other is GS9137. And essentially, they both show very rapid declines in the virus, extremely rapid declines. When you look at the time frame of how quickly does the viral level drop after you start giving med, very quick. So that's a very encouraging thing to most people who look at this type of data. And I'm not sure about this, but I thought I'd heard that the Merck drug is going to expanded access, which is a little surprising to me because there's not a whole lot of data out there. I'm sorry? Yeah, it's low numbers of patients because this drug was in, I think it was just phase 2 studies. And so, I mean, the issue is that it's a very active drug, clearly, and the concern always when stuff like that happens is simply that there's less information about it from a safety perspective, and even though it looks very good. And there's a question over here.
Well, I just wanted to contribute that it actually, they themselves were very concerned as we were going forward with advancing to expand access early, although we needed it for certain patients
Right.
who absolutely had to have
Right.
a drug. So they themselves said, yes, it looks so good, even in small numbers, that rather than wait until January, they do it right now.
Yeah.
So they'll very
So Fred's point's well taken, that for folks who really have a lot of drug resistance and are not in a safe situation because they have such advanced illness and no good options right now to be able to have access to a drug that looks so great, this is exactly why expanded access exists. It's just it's a little unusual that it's coming out that early in its research process. What I didn't go into is that there are actually very strict criteria for someone to have access to a drug through expanded access. And what has been just pointed out is that this particular drug, indeed, you have to have a lot of drug experience before you would even qualify to get it. So somebody who just was diagnosed and says, wow, I read about this new med, I want to go on that one. It's like, no, we have other things that we know work and we know much more about them, so we're not going to go this way. And actually, we can't go that way. We can't get into that study with that. Does that help? Okay. Maturation inhibitors, there's really only one drug that I'm familiar, having read about, not really familiar with, have read about, that looks promising. And again, early in its studies, it's in phase 2, but it has a very long half-life, which we always love because it means the patient doesn't have to be taking the meds so frequently. And it appears to be synergistic with the other meds out there. In other words, it's not just an additive effect, it's more than additive. When you put 2 and 2 together, you get more than 4. That's the initial look at it. So this just gives you a sense of maybe when things might come. No promises here. Well, we know this year, of course, that this is available. And I guess Dupranavir came out last year, not sure. And then we've got the possibility for the future of these R5 inhibitors. And we've got these integrase inhibitors. and we've got this maturation inhibitor. So based on where they are in the process now, this sort of gives you a sense of a timeline. These two are both NNRTIs, and I didn't talk about this one, and I actually don't remember the date on it, but there's a couple new NNRTIs coming out. This is one of the new protease inhibitors we talked about, and we don't even have other nukes up on there, so I'm not sure where they're looking at, probably further out in the future. And I didn't talk about this, but there are some X4 inhibitors. That's that inhibition of those really more concerning coreceptors, because the X4 utilizing viral strains are usually in more advanced disease. So some people have thought, you know, maybe what needs to happen is you combine an R5 and an X4 inhibitor in order to safely treat somebody if you're going to block that step. But to my knowledge, we don't have information on that. Okay? So I'm going to switch gears. So I'm going to talk about some things that clinically we see. One is MRSA. Has anybody heard of MRSA? Yeah, MRSA stands for methicillin-resistant Staph aureus. So it's a bacteria, been around a long time. What's different now is that we see it much more in the community as opposed to in hospitalized patients. And it's particularly more common in folks who have HIV. So community-acquired MRSA is the term that's used. And it's not that it's untreatable, it is. It's just that you have to know you have that strain in order to choose the right antibiotic. And that's because of the resistance that it shows to current antibiotics, or to the commonly used antibiotics for skin infections. So it's in people who have HIV, when someone has a skin infection that needs antibiotics, we usually are routinely choosing meds that are different than we might choose in someone else. So the other thing is that a lot of times this just needs to be drained. In other words, if you have a boil or an abscess, just opening it up and draining it is oftentimes enough to treat the infection, okay? You don't always need antibiotics. It depends on how severe the infection is, but it can lead to quite severe infections. IRIS is a term you may or may not have been hearing today, which stands for the Immune Reconstitution Inflammatory Syndrome, which is a term referring to a number of different clinical situations that basically have to do with the immune system getting stronger because of treatment, recognizing an infection or what we would call a pathogen, a type of infection that's present in the system, but at such a low level that it hadn't been causing trouble, even though it was going to if you let it go. Now that the immune system's strong enough to go get it, it goes and gets it, and it really goes and gets it, and there's a lot of inflammation. And so what it does is it changes the way somebody clinically presents with whatever that problem might be. So an example would be what we call MAC, or Mycobacterium avium. People might have been familiar with that term. When people used to get it in the past with really low T cells, they would gradually get sicker and sicker and sicker. Fevers, weight loss, diarrhea, feeling crummy, no energy, etc. And you would find that infection oftentimes in the blood because it was all over, and then you would have to treat. Now what happens is maybe you have a little bit of that in your system, not enough to make you sick, but it's there. And when you start the treatment, your immune system gets stronger, and suddenly it recognizes it. So it pulls it all into a lymph node to try to get rid of it, but it also makes it incredibly inflamed. So you end up with these incredibly hot, tender, swollen red lymph nodes because your body is actually getting after this infection, but it makes a very dramatic presentation, which is totally different than the way somebody would be diagnosed with MAC in a different situation. So that's just one example, and they're lumped together in this term IRIS, okay? In a way, it's a good thing, believe it or not, because it means your immune system's getting stronger. The problem is you got to deal with that particular event and figure out how to treat whatever the infection is and get somebody through it. We try not to stop HIV meds because this is exactly, in a sense, what we want. We want a stronger immune system. We just don't want the bug that's causing trouble around. Primary resistance. This is a term that refers to someone who becomes infected with HIV and becomes infected with a resistant strain. So it's not all that surprising when you think about the fact that even in this country, we still have about the same number of new infections every year, and we know there's a lot more people on treatment who have resistant virus, so not surprisingly, some of those folks who become infected with resistant virus. So they're behind the 8 ball from the get-go. because they don't have the options of all the drugs that we might be able to choose from. The only way we can know that is to go and look to say, what does your virus look like? So that leads into one of the recommendations these days around treatment, which is if you have a newly diagnosed patient, you should be looking at their virus for resistance in the beginning, even if you're not planning to treat them at that time, because you want to know for the future, do they have resistance to medications? Because if you don't know that, and let's pick an example, say you have resistance to Sestiva. A lot of people like Sestiva. It's in that new drug Atripla, right? Well, if you have resistance to it and you give them Sestiva plus 2 other drugs, you're giving them 2-drug therapy. And the last time 2-drug therapy was recommended was long ago. So you're not doing them any favors. They're probably going to get more resistance. So you got to know. And there's a variety of different data sources looking at what the rate of that is in newly diagnosed folks. And depending on where you look and in what years you look, you'll see a range, but it generally is between 10 and 15%. And at our own clinic, it's about 15% over the last 2 years. So about 15% of newly diagnosed folks will actually have a significant mutation. In other words, they definitely have some drugs that are not going to work for them right up front.
Is that related to, I was under the impression that a lot of that was related to where they actually infected the virus.
So the question.
More prevalent in certain areas as opposed to.
So the question has to do about, is that true in every geographic locale, really? And it really has more to do with who you became infected by as opposed to where you became infected, because you may have a visitor from out of town, or you may be a visitor from out of town. And what most places are finding is that, especially if you're in a city in this country, there's enough back and forth and traveling around that this is pretty common. I don't know any data from small towns. I mean, I don't know of any data sets that tracks that, but I would say that the more mobile anyone is, the more likely that this is not going to be that different.
So are you suggesting that they get a genotype as soon as they're diagnosed?
I'm sorry?
Are you suggesting that they get a genotype as soon as they're diagnosed?
The question is, should someone get a genotype as soon as they're diagnosed? And the answer is yes. Okay. Superinfection. Basically what this means is getting infected with HIV more than once. Is this a term that people are familiar with? You've probably heard your doc or somebody talk about it. It's an ongoing sort of issue because you've got folks who say, well, I'm already infected and my partners are already infected. I only have sex with people who also are infected, so what's the worry? And of course the worry is you too can get a resistant infection that you didn't have before. And that's been shown to happen to folks. So I put it out there because it's not just as simple as I'm already infected, I don't have to worry. The same thing can happen, yes?
How prevalent is superinfection? Because I've heard and read things say that it's not a real big deal. I guess you're presenting it here, saying that it is.
Well, in terms of the prevalence, I don't think there's any good data. But I think the reason that I put it up there and the fact that I would say it's a big deal is that it's like getting HIV the first time. How prevalent is it, and do you need to use condoms because it's not that prevalent in the city you're visiting, or in your town there aren't that many, or you don't think there's that many, and then you get infected, right? How many chances out of how many? What's the prevalence, and then what's the importance? The issue is it may not be all that prevalent, but that doesn't mean it won't happen. And if you pick the wrong situation, it may happen to you. So I can't give you numbers other than to say that it's definitely been documented to happen, and if you get that other resistance that you don't already have, then you've just entered a new phase of how to treat your HIV. So it's something to be aware of. Yes?
So is there any way of knowing, or any tests or anything that show you that you are resistant to the types of drugs before you start?
Say again, is there any test that does?
Test or way of knowing if you're going to be resistant to certain types of drugs before you even start, or is it just a
Yeah. Well, yes, that's there. So the question is, are there any tests that can tell you if you're resistant to any drugs before you start them? And the answer is yes, and it's called a resistance test. The problem is it's not quite as simple as it might sound. If someone is newly infected, you're going to know by doing that test what they're resistant to or not, and therefore make a decision about what to start. If somebody's been on drugs in the past and is now off them, They may have developed resistance to those drugs or one of those drugs in the past, but once you stop the meds, the virus that becomes most prevalent in your system is the virus that is the best at doing what HIV does, and that is what we call wild-type virus. In other words, unmutated, I've already been here before, I figured out what's best, I know how to get you. That's the virus that's going to be in your blood. It's only under drug pressure, it's only when drugs are present that the mutant has an advantage. So if you've been on drugs in the past and you stop them and maybe had some resistance, and it depends on what happened and what were your labs showing and how did you stop them, you might have resistance that can't be detected at the time that the test would be drawn later in the future. Does that make sense? Okay.
So why does that not happen in like somebody who's really
In someone who's newly diagnosed, it actually can eventually happen, and that's why the recommendations about when to test when somebody is newly diagnosed actually recommend that if they've been infected within the last 2 years, then you should definitely do it, and if it's been longer, that you try to decide whether you should do it or not. There isn't really a good way to be absolutely certain, and without getting too technical about it, the long and short of it is, if you got a resistant virus up front, it's going to hang around for a while. It has to what's called back mutate to become wild type. If you got infected with wild type and then were on drugs and got resistant, you already have both styles in your body, and so the wild type can come back very quickly. So it's a bit of a different situation, okay? Over here. So the question is, if you're resistant to drugs, many or few, can you in the future go back to taking one of those drugs that you've been shown to be resistant to? Did I get that right? Okay. Well, the answer is you can't go back to taking them and expect them to be effective. And the reason is that same old lifestyle. That was a slip. Damn you. Life cycle. Remember how it integrates into the DNA, and then those cells have to be destroyed before that viral, that strain of the virus would be gone. Those get what we call archives, stored in resting cells. These are just the terms that are used. But basically, cells that are still living have that old virus stored in them so they can reactivate. And that's where it comes back from. So there may be a lag period, and there were some initial studies that said, hey, if you take people off their meds and wait a while and then go back to old meds, you really get this great response. But it was very short-lived. And the reason is the resistance is not going away. Multi-drug resistance, we've sort of touched on this. It's basically the idea that strains of virus can have resistance to multiple drugs. And I don't think that's a surprise to people who are living with that, but it's just a concept and a name that's thrown about. Okay? Okay, other topics. Lipodystrophy, another favorite. And I know I was at the end of Jim's talk where he was essentially describing all of the confusion and uncertainty around this in terms of why does it come about and what can you do. And the problems are that we don't really understand the exact causes of the lipodystrophy, and even the term. I mean, let's just be clear what we're talking about. Lipodystrophy means basically changes in fat. And so it can be either fat gain, which you typically see in what's called the viscera, the gut around the internal organs, and is usually manifested by somebody just gaining inches in their midsection. Or it can be fat loss, which typically can be either in the face, in the limbs, or the butt. You also get folks who gain some either in the neck, the breasts, or right back here, so-called buffalo hump. So there's a variety of different things that somebody's body can change in terms of how fat is stored, and it can be a combination of a variety of those. There's also changes in cholesterol, lipids, and that type of thing as well. So it gets, and they're probably related in some way because we see associations between people having more than one of those. The problem is we're not good at treating it. So the cholesterol problems we can treat, but the one that I think really bothers people is what they can see and what they look like, and what can we do about that. So there was recent information from the international meeting about the use of, and this has been looked at before, recombinant human growth hormone. And the long and short of it is it showed benefit, but it didn't last because eventually people had to either go down in the dose, or in this study they were only treated for a certain amount of time, and when they went down on the dose or stopped it, it came back. And human growth hormone has its own side effects, some of which add to the problems with insulin resistance, the high sugars, as well as some of the cholesterol changes. So it's by no means takes care of everything. And the other thing is it's incredibly expensive, so a lot of places won't pay for it. And as I mentioned, it also wears off if you stop it. So you can get, and it doesn't completely resolve the problems. There's measurable changes, but whether they're visually dramatic, I don't know. I didn't see any pictures from that. Yeah, and the comment was that it can make your nose and ears grow, and that's that's true. I mean, we have this hormone in our body for a reason, and it's usually when we're kids, and it's so that we grow. And so afterwards, when you're not a kid, there's a reason that we don't have so much of it. So like every other thing we do, if we muck with the way things are supposed to be, we're going to have side effects. So we may get some advantage from one, but there's going to be other disadvantages, and edema, and blood sugar problems, cholesterol problems, pain, achiness, big ears and noses. These are things that can happen. So that was the only sort of new information that I thought was impressive, or potentially. There is, for the facial, there is a product called Sculptra, which is actually a, I can't remember the type of chemical it is, but it's basically an inert substance that's injected, and it causes fat to build up around these injection sites. And the folks who use it, the specialists who use it, can actually get people's facial loss to fill in. The problem is that it's definitely considered cosmetic, and it's not cheap. So it's not routinely available unless you have a checkbook. But it has, people have been pleased with what they've gotten. There are a couple of folks in town doing it. Looks like there's some genetic issues around lipodystrophy as well. When they looked at folks who had the body changes compared to folks who didn't, or who had different levels of it, there were clearly some genetic associations in terms of some specific markers that they looked at genetically. And it's really just sort of the beginning of looking at that type of thing. There is no test that you can do to say, I'm worried that this person's going to get it, so I'm going to do this test and then I'll not choose certain medicines. We already choose our medicines based on trying to minimize this. So even if we had this information, it may add to the ability to predict your risk, but it's not going to change what we can offer you. We don't have a treatment, and we don't have meds as of yet that are clearly without this effect. There are just some meds that clearly have more of an effect, and we try to avoid those. Other stuff has pretty much been disappointing. The whole business, maybe some of you are familiar with the meds metformin, glitazones, and testosterone, have all been looked at to just try to reverse or minimize the changes in the body, fat storage, and none of those have been shown to really make a difference. One thing that definitely appears to be helpful is to take people off a thymidine analog. So if somebody's having loss of limb fat, that's really the thing that's been shown to be changed by this. So if you've got the loss of subcutaneous fat and veins more prominent, switching somebody from a thymidine analog, AZT or D4T, to something else to replace it has shown a very slow but incremental gain in subcutaneous fat over time. A lot of people don't actually notice it when they ask the people, but it's measured as it. So it's not dramatic, but it is slow. Other issues, neuropathy, I think Jim was mentioning as well. You know, we tend to see less of it now, I think, because we don't use the meds that were classically causes of it. There's a study going on right now over at R&E for pregabalin. That's the only new drug that I'm aware of. A lot of people use Neurontin if they've got it, and then a variety of other pain medicines, or sometimes some of the antidepressants have been helpful to some folks for the pain, not because of the depression, but they probably get because of the pain too. So we're going to be starting doing anal pap smears at the county clinic. It's sort of a controversial issue in the sense that the data is not great, but there clearly are higher rates of anal cancers in people with HIV, both men and women. And that's also true in men who have sex with men who are not HIV infected. They have higher rates as well, associated with, it's very similar to the way that cervical cancer occurs in women. The virus that causes cellular change is called human papillomavirus, and there's a whole bunch of different types. Some of them cause warts, some of them can cause cancers. You can look for changes with a pap smear, just like you would do on a woman for a cervical check. And then if there's abnormalities, you can do this procedure where you can see things better, and that's called colposcopy. So that's coming to our clinic. And then hepatitis C treatment, I know there's whole other talks that have gone on about it, and I'm just going to point out that we're gearing up to start treating that at the county clinic as well, instead of having to refer out. Old problems, new approaches. Well, microbicides is sort of a big thing in the international discussions, because they're really looking to see, is there some way we can prevent transmission? And is there some way of doing that as a sexual lubricant or gel that would kill HIV virus if it came in contact with it? And so there's been a variety of different ideas and different studies. There's about 15 of them that I could find that are ongoing. So the data is by no means clear in how they're going to pay for them. Some of them are using medicines that are currently available, but putting them in a gel format or in a ring format around the cervix. But the cost issues and all, I have no idea. I haven't seen anything on that. But it's one of the approaches towards prevention. The other is there's a lot more emphasis on counseling in terms of prevention for positives is the term that's frequently used. In other words, trying to remind all of the folks that know they're positive that, you know, this is one way of helping prevent infection is to actually know how to prevent infecting somebody else. And of course, the ongoing issues around educating people who are not infected about how to prevent getting infected. There's some talk about pre-exposure prophylaxis, and this has to do with taking medicines to prevent transmission. There's only been a couple of studies that really they're not particularly good in the sense that they're very hard to do. There's a lot of talk, I don't know how much there is of happening, of people just on the street just doing this, just saying, I'm going to be out, it's going to be the weekend, I don't want to have to worry, I'm going to take a medication. And the drug that people talk about a lot is using Viriad, which is one of the HIV medicines. There's no good data, but this is what some folks have been doing. You know, the concern would be that, number one, you could get a problem with the medicine, and number two, is you don't know whether the person you're with may or may not have resistance to that already. And then number three, if you did become infected but you don't know it and you keep taking this, then you run the risk of obviously getting resistant to that because you're taking single drug therapy. So there's a lot of issues about, is it a smart thing? Is it not a smart thing? What does the data show? And there just isn't a lot to be said about it. But it's out there, and people may have heard about it or done it themselves, I don't know. Male circumcision's becoming more and more talked about as a prevention method, particularly in Africa, is where the studies have been done, and also in India. And we could probably talk back and forth about why the studies are being done there, but the point being that they've shown decreased rates of acquisition of HIV in HIV-negative men who become circumcised compared to their cohorts, those who were not circumcised in the same areas, in the same demographics, et cetera, that the rate of acquiring HIV is substantially lower, ranging anywhere from 40 to 65% less. And actually also showing decreases in female partners of HIV-positive men, that if the men are circumcised, they transmit less to the women. So the question is, you know, what's the mechanism? Does it have to do with the foreskin holding some of the infected material in some place and holding it against the membranes? And it's probably, for the women, I'm not sure of what that might be, but in men, in everybody, there are cells in the mucosa that process infections like virus that come in through the mucosa. And those cells sort of become little storehouses of where that virus is going to be dealt with. And if that dealing with it means you can't kill it, but it becomes a way of reproducing, that just provides a lot of surface area and a lot of mucosa for those cells to be there to pick that virus up. So it's thought that that might have a lot to do with it. They're called dendritic cells. How many minutes do I have left? Well, okay, old meds, new news. Structured treatment interruptions. I know Jim went over this, so I'll hit on it briefly, but the main thing here is that the thought is, well, so first of all, what is it? It's stopping your meds, basically. Structured treatment interruption just means you planned it. So, you know, whether it's planned or not, people tend to use the term STI for all sorts of reasons. Medical reasons, somebody's getting sick from their medicine, personal reasons, I'm sick of my medicine, and then toxicity reasons. I'm sick of my medicine too. So The problems are, you have to think about the idea of how you stop, because the issue is resistance. As always, we worry about resistance. So stopping medicines and having drug in the system at this lower level as you stop the medicine, that's the perfect situation. You've got drug around and the virus is starting to come back, and you worry that you're going to get some mutations that lead to resistance. So that's one worry. But really the biggest worry is the studies that have been coming out around doing this. And the biggest study so far anywhere in the world, and it was actually a multi-country study, was this so-called SMART study, which I forgot what it stands for, but it was a very smart name. And it showed that it was just not a good idea, because virtually everybody in the group that was on the on and off arms of the study had higher risk of death and higher risk of opportunistic infections. And that was true across all CD4 strata. In other words, no matter what level your CD4 was at when you did this, you got into trouble. So this sort of put the brakes on this idea for a lot of people, because most people thought that was not going to happen. There had been some earlier studies, smaller studies, that looked like it was safe to do if you made these decisions of when to go on and off based on someone's T cells. In other words, don't let them get too low, stop them if they're nice and high. And that was the way the SMART study was designed, but it did not replicate some of the smaller studies. It actually got stopped early because of this finding. So it's a bit of a concern. Now, there may be certain situations where it'll pan out that maybe this is going to be okay, and some people are arguing that the T cell levels that were used to go on and off were not appropriate, that maybe if they had used higher levels, they would have not gotten into this trouble. But I think the point being that as a general rule, this is not something that would be recommended in terms of how to manage somebody's HIV. And again, there were other studies more recently that basically are showing the same thing. So there's a lot of concern about that, about whether that really is going to be a smart idea, at least as a planned thing. People obviously go on and off their meds for a variety of reasons, but to actually come into the office and say, I think what we'll do for you is have you go on and off for the next 4 years, you probably don't want to hear that. There was some data on monotherapy, which is pretty interesting. The concept, there's a question somewhere. Yes? There. The comment is that the idea of stopping meds may come from the past, where the idea of medication holiday was really around the issue of toxicity, difficult meds to take, and that was just something that was needed, at least for some people, in order to survive taking their medicines. And that's certainly true. That was an idea that was there from long ago. It really gained traction actually around the issue of people who were treated for acute infection. That's where it really gained in the research world, because the thought was, wow, if we treat people as soon as they get infected, maybe they'll be strong enough after treatment that we can stop their meds. And then that kind of took off from there into other studies and other groups where the docs and the providers were sort of looking at this idea, as opposed to patients saying, I can't do this anymore and I got to take a break. So I think it was originally, like you said, patient groups, and then subsequently interest from both ends. And now sort of coming to this position where it doesn't look so smart, at least from that big study. Okay? So the monotherapy issue. Generally speaking, we say not a good idea. Monotherapy, you know, one drug's not enough. We've done this, 1 drug, 2 drug, now we're at 3 drugs before we finally got control. The difference, I think, is that some of the newer drugs are extremely potent. And so what they did in a couple of studies, and they're fairly small, is to take people who have very good control on standard triple drug therapy, including Kaletra, and say, we're going to stop the other 2 drugs and compare you to how your friends do who keep on all 3. And then they follow them over time. It was a very long study, 96 weeks. And basically it showed that the control was as good. Now, it hasn't been replicated. There were a couple other smaller studies that looked at similar designs, but there's enough out there so it's on the radar that maybe there's this possibility that you could simplify. But I would not walk out of here thinking if you're on a Kaletra regimen, it's okay to just stop the other meds, because this is really initial information, and I would just caution people, we oftentimes hear things early on, they sound great, they don't always turn out to be, so it's just something to think about. For the future, this may become an option, and there may be certain subgroups of people that it clearly is safe in and others where it clearly isn't, and we don't know that yet. Okay? There's also been some studies looking at other protease inhibitors compared to Kaletra. Kaletra's been of late, the preferred protease inhibitor when you look at the DHS guidelines. The IAS, which is another organization, the International AIDS Society, which is different than the Department of Health and Human Services, changed their guidelines to include other boosted protease inhibitors because the data has been looking good for those as well. In this particular study, there was a head-to-head with Kaletra and Lexiva, both boosted. Obviously, Kaletra already has ritonavir in it, and they had equivalent outcomes over a long period of time. And so now the IAS guidelines actually include boosted Lexiva, boosted Rayataz, and boosted Inverase as acceptable initial therapy for somebody, as well as Kaletra. That hasn't changed with the DHS guidelines. And then just to not forget, things really are better these days. This is a graph that shows the deaths at my county clinic over these years. So you can see ever since we got therapy that works, our deaths have gone from 100 a year down to between 10 and 20. And I'm done.